Welcome to the deep dive. Today, we're plunging into something really critical, but maybe a bit hidden sometimes. The huge stress families face when someone's in intensive care, the ICU.
It's immense. We're talking up to 60% experiencing really negative mental health impacts. It's staggering, really.
Absolutely.
Yeah.
And best practices, the guidelines, they all say ICUs should actively partner with families, support them.
Right. But that's where we hit this wall, this no-do gap, as it's called.
Oh,
We know we should be doing these family-focused things, but, well, they often only get partly done. And honestly, there's not a great understanding of how to actually get them working properly in such a busy, high-pressure place like an ICU.
that's the crux of it. So our mission today is to really dig into a specific new approach to family support intervention, or FSI. It was designed for adult ICUs over in Switzerland. We want to unpack the real-world side of it, the challenges, the successes of putting something like this into practice, see what works, what doesn't, and crucially, why.
Okay, so let's break down this FSI. What is it exactly?
Well, it's described as nurse-led, which is key but also interprofessional.
Meaning the whole team has to be involved.
Exactly. It's not just one person's job. It's got three main parts.
Okay, what's the first one?
First up is early engaging and liaising. This is all about building those relationships right from the start, getting families involved, making sure they're connected with the whole ICU team.
So communication and coordination, basically.
Yes, coordinating care, thinking about transitions out of the ICU, even follow-up, making them feel like real partners.
Right, not just visitors hovering anxiously. Okay, component 2.
The second is supporting, and this happens mainly through what they call therapeutic family conversations.
Therapeutic conversations sounds quite specific.
It is. These aren't just quick chats. It's about the nurses assessing what the family needs, their burdens, sure, but also their strengths, their resources. It's partly about building that trust, that relationship, and partly psychoeducational, helping them understand.
Got it. And the third piece. The third is communicating. And this involves structured, interprofessional family meetings.
So bringing everyone together formally.
Precisely. Nurses, doctors, and the family all sitting down for shared decision-making, making sure everyone's on the same page about the patient's care.
Okay, that sounds comprehensive. How did they actually make this happen on the ground?
Well, a really important part was introducing a brand new role, the family ICU nurse, or FN.
A dedicated person.
Yes, someone whose specific job was to oversee and deliver this FSI, working closely with, everyone else, doctors, other nurses.
Interesting. So how did they study this? You mentioned it was part of a bigger trial.
That's right. It was part of the FICUS trial. And that was what they call a hybrid effectiveness implementation study.
Hybrid, meaning?
Meaning they weren't just looking at, does this intervention work in theory, but also, can we actually implement it in the real messy world of an ICU?
Okay. So effectiveness and practicality.
Exactly. It's crucial because, a great idea on paper is useless if you can't actually make it happen day to day. So this paper we're focusing on, it's a process evaluation. It zooms in on the how did the implementation actually go?
Makes sense. You need both pieces. So what was the study design for this implementation part?
They used a multiple case study approach. So they looked at 8 different ICUs in Switzerland.
Okay.
And instead of just pooling all the data, they treated each ICU like its own case.
So they could see the unique challenges in each place.
Precisely. It gives you a much richer picture than just averages. And this ran for about a year, June 2022 to July 2023.
Was there a particular theory or framework guiding how they looked at implementation?
Yes, they used something called normalization process theory, NPT.
NPT.
Yeah, it's basically a way to understand all the work people have to do together to make a new practice, like this FSI, just a normal part of their routine.
Okay. How does it work?
It has 4 major ideas or constructs. First is coherence. Do people actually understand the FSI? Do they get why it's needed?
Makes sense. Understanding first.
Then, cognitive participation. Are people actually willing to engage? To invest their effort? Are they bought in?
Right. The commitment factor.
Third is collective action. What are people actually doing to make it happen? What are the practical steps?
The doing part.
And finally, reflexive monitoring. Are they looking back? Are they assessing how it's going, making adjustments, learning from it?
Coherence, cognitive participation, collective action, reflexive monitoring. Okay, it covers the whole cycle. Who actually took part in the study from these ICUs?
They had 40 key clinical partners, KPs. This group included the local nurses who were championing the FSI,
The implementers.
Right. And nurse leaders, physician leaders, people with influence, and of course, the new family nurses themselves.
So a mix of roles, and how did they collect the data on how things were going?
They used mixed methods. So for the qualitative side, they did 16 small group interviews.
Yeah.
They did these twice, once around 3-6 months in, and again at 9-12 months. And what was really neat was these interviews also served as implementation support meetings.
Ah, so data collection and problem solving at the same time.
Exactly. Really efficient. People could talk through challenges right there.
Smart. And the quantitative side, what numbers did they collect?
They used questionnaires at the midpoint, standardized ones like the AIM for acceptability, FM for feasibility, IM for appropriateness,
Okay.
and one called NOMAD, which measures those MPT constructs we just talked about, how normalized the intervention was becoming.
So validated tools to get measurable scores. Anything else innovative about their methods?
Yeah. Besides the dual purpose interviews, they also created this unique 3-level system: high, moderate, low, for categorizing their implementation indicators.
Why was that useful?
It just made things really clear and comparable. You could easily see which aspects were being adopted well and which weren't, and maybe compare across the different ICUs. Helps for future work, too.
Okay, so we've got the intervention, the study design, the framework. Let's get to the results.
Hmm.
How did people actually feel about this FSI? Let's start with acceptability. Did they like it?
Overwhelmingly, yes. The qualitative feedback was really positive. The KPs found it agreeable, and acceptance actually grew over time.
Why did it grow?
Mainly because of the positive feedback they got directly from families, and the family nurses themselves saw they were building, deeper, more trusting relationships.
That's powerful feedback.
Definitely. One FN said, "We have received only positive feedback from families. They are very grateful because someone takes care of them."
Wow.
Another mentioned the relationship with the families is different. Now I experience more trust and continuity.
So real validation from the families themselves. Did the numbers back that up?
Absolutely. High acceptance across the board. Like
Mhm.
90% or more of the ratings on the AIM scale were 4 or higher. Widespread buy-in.
Okay, so they liked it. Big tick there. What about appropriateness? Did they feel it was the right tool for the job, addressing the family's actual needs?
Yes. Again, very high agreement here. The KOPs saw it as highly relevant, especially those therapeutic conversations.
What do they say about those?
FNs felt they really allowed families to talk about their situation, their burdens, but also, importantly, their own resources, their strengths.
Ah, empowering them too.
Exactly. One FN put it as, therapeutic conversations give families the opportunity to talk about their situation and to recognize their own resources.
That's great.
And they also saw the value even after discharge. An implementer mentioned how helpful the conversations were a month later, just for families to reflect on everything. They heard that feedback a lot.
So it met a real need, even in the longer term.
Yeah.
And the quantitative data.
Matched up perfectly. 95% or more ratings were high on the appropriateness scale, IAM, so clearly seen as the right fit.
Okay, so high acceptance, high appropriateness. Sounds great so far. But the big question, feasibility. Was it actually doable in the real world?
Yes, this is where things got, let's say, more complex. Feasibility was definitely perceived as lower than acceptability and appropriateness.
Why was that? What were the barriers?
A major factor, interestingly, was the study itself.
The study. How so?
The FNs felt constrained by the trial's rules, the need for standardization, sticking rigidly to the protocol, getting consent before acting.
So the research structure sometimes got in the way of immediate need.
Exactly. Sometimes families needed support right now, but the protocol meant they had to wait for consent. One FN said, "It's just the study timeline that puts pressure on it. It would be more convenient if I could just do it when it fits to families' needs."
That's a tough spot for a nurse to be in. Were there other issues besides the study rules?
Oh yeah, just the classic challenges: time and resources. Staff capacity was limited. The FNs were often trying to deliver this specialized family support while also doing their regular patient care during busy shifts.
The juggling act.
Right. As one FN put it, sometimes the delivery of the family support intervention is challenging for me because the organization and participation is time-consuming. Another said it was sometimes not feasible, especially while simultaneously caring for patients.
That sounds incredibly difficult. How did this show up in the feasibility scores?
It was reflected there, definitely. The quantitative ratings for feasibility varied quite a bit across the ICUs. Some were high, up to 95%, but others were only moderate, down around 63%. Much more variation than for acceptance or appropriateness.
So a real mixed bag depending on the site and maybe the pressures there. Okay, let's shift gears to how the implementation progressed using that NPT framework. First, coherence, the understanding part. Did everyone see the FSI the same way?
Not entirely. There were definitely different attitudes, especially about those interprofessional family meetings.
Hmm. Like what?
Well, some physicians questioned if so many were needed, or if they really needed to be there every time, especially if they had already talked to the family.
A time pressure issue again.
Seems likely. One P lead, a physician leader, actually said, "I'm wondering if so many interprofessional family meetings are necessary, and especially if my participation is needed."
Okay. Any other coherence challenges?
There was also some initial hesitancy from staff nurses about the new family nurse role.
Why? What were their concerns?
Some felt it might be a loss of their own professional responsibilities, maybe undermining their role with families.
Ah, turf concerns almost.
Sort of.
Mhm.
An implementer noted exactly that. So again, the quantitative data for coherence was mixed moderate to high. Not everyone was fully aligned on the what and why initially.
Okay. What about cognitive participation?
Yeah.
Getting people engaged and committed. How did that go?
This was actually a really strong point. What stood out was how the family nurse's own experience really boosted their commitment.
How so?
Initially, they were a bit unsure, maybe worried about what to say in those therapeutic conversations. But as they did more, reflected on it, their confidence grew. They saw the impact. Peer support helped too.
So, learning by doing and seeing the value solidified their buy-in.
Absolutely. And FN said, self-reflection helped me a lot. The more you do it, the more confident you feel. And they became really motivated because they saw how important the FSI was.
That intrinsic motivation is powerful.
Hugely. Another FN said the conversations were very enriching and important and motivating me to continuing. And the numbers showed this cognitive participation was the highest rated NPT construct, over 85% high ratings. Once they were in, they were all in.
Great. Now, for collective action, the doing part. Given the feasibility issues and differing views, how did teams actually make this work?
They got creative and adapted, for instance, to ease those staff nurse concerns. FN started actively inviting them to participate in the family meetings. And one FN noticed, since I ask staff nurses to participate, their hesitancy towards the FSI has decreased.
Smart. Involving them directly. What about scheduling those tricky meetings?
That took effort. They had to adapt schedules, work around physician availability. One FN said they organized things according to the physician's planning, so workflows weren't disrupted.
Being flexible.
Very. Some ICUs even started doing short prep meetings before the family meeting just to align goals and roles and avoid confusion.
Proactive planning. Good idea.
Right.
Did they ever have to sort of bend the official protocol?
Yes, particularly around physician time. Sometimes the doctor would come in for the key medical part at the beginning,
Right.
and then the FN would continue the rest of the meeting, updating the doctor later. It was a practical workaround.
Adapting to reality.
They also set up new communication channels, like using mobile messages for quick updates, especially important when people were off shift.
And leadership. You mentioned it before. How important was it here?
Absolutely essential. FNs really highlighted how ongoing support from their unit leaders, giving them flexibility, autonomy, coaching, helping with communication was vital for them to actually do the job.
Makes sense. So collector action scores. Still mixed.
Yeah, reflecting those ongoing efforts and challenges.
Yeah.
Range from moderate 71% up to high 93%. Some sites managed better than others.
Okay, last NPT bit. Reflexive monitoring. Were teams reflecting, learning, seeing improvements?
They definitely reported seeing positive changes, better interprofessional collaboration, more mutual support. One FN felt they developed a shared interprofessional understanding.
That's a big win.
Huge. And there were practical benefits, too. Physicians appreciated FNs taking over the documentation for family meetings, a win-win situation, as one P-lead called it.
Relieving a burden. Nice.
They also noticed just a generally increased team awareness of families and felt the quality of the family meetings themselves had improved significantly.
So definite perceived benefits, but how did the scores look?
Interestingly, while the qualitative feedback was quite positive, reflexive monitoring actually had the lowest quantitative scores, ranging from moderate 64% to high 92%.
Why the disconnect, do you think?
It might suggest that while improvements were noticed, the formal process of consistently reflecting together as a team specifically to optimize the FSI might still have been developing or facing challenges. Maybe it's harder to find time for that reflective piece.
That makes sense. It often gets squeezed out. Okay, this brings us to a really interesting finding. The implementation pathways. You said they found two distinct groups among the ICUs.
Yes, based on all this data, they saw two clear patterns emerging. They called them early adopters and protracted adopters, 4 ICUs in each group.
Okay, tell me about the early adopters. What did they look like?
These guys, well, they seem to click with it right away. Consistently high scores on everything: acceptability, appropriateness, and feasibility.
Even feasibility.
Even feasibility. And they scored high on all 4 NPT constructs, too. They basically hit the ground running, showed high implementation levels early on, and just kept going.
Impressive. So what about the protracted adopters? What was their journey like?
They also had high acceptance and appropriateness. They liked the FSI and saw the need for it. But the key difference was moderate feasibility.
So those practical challenges, the steady constraints, hit them harder.
Exactly. Those issues seem to stick around longer for this group, and their scores on the NPT constructs, coherence, collective action, reflexive monitoring, were more mixed. They were struggling more with the integration into daily practice.
So it sounds like the study setup might have played a bigger role in slowing things down for them.
That seems to be a key factor distinguishing the pathways, yeah. The
Mhm.
rigidity, the timeline, it was a bigger hurdle for the protracted group.
But did they eventually get there? Was there a catch-up?
Yes. And this is really encouraging. By the second time point, 9 to 12 months in, the protracted adopters had significantly improved. They actually caught up to the early adopters' implementation levels.
Wow. So even with those initial hurdles, persistence and support paid off.
It really seems so. It suggests that these challenges aren't necessarily permanent roadblocks. With time and the right support, even complex things can get embedded.
That's a fantastic insight. It highlights how implementation isn't always linear. Okay, let's pull this all together. Why does this matter? What are the big takeaways from this deep dive?
Well, first, it just powerfully underscores the human side of ICU care. Supporting families isn't optional, it's crucial for their well-being, and this shows concrete ways to do it effectively.
And it's a great case study for implementation science itself, right?
Absolutely. It drives home that a good idea isn't enough. You have to understand the how, the barriers, the facilitators, the context. That's what makes the difference between an idea on a shelf and an idea that actually changes practice.
So what were those key success factors that emerged? If someone listening wants to implement something complex, what should they focus on?
Okay, several things. High acceptance and appropriateness are crucial starting points. People need to believe in it.
Right.
Strong commitment from the key players on the ground, having enough staff and time, that feasibility piece is huge.
The resource question.
Definitely. A culture that already values interprofessional collaboration and family care helps immensely. And as we saw, active, supportive leadership is non-negotiable.
Leadership setting the tone, providing resources.
Exactly. Plus, having dedicated implementation support, whether internal or external, and importantly, allowing for some flexibility and adaptation even within a structured approach. Things rarely go exactly to plan.
So it's about anticipating and addressing the barriers, workload, staffing, different attitudes proactively.
Precisely. And for leaders, for policymakers, the message is clear. Think about implementation support upfront. Don't just launch something and hope for the best. Assess the skills, the capacity before you start, and provide the necessary support.
It's about setting the stage for success.
Completely.
So here's a final thought then. If even within a controlled clinical trial, things like flexibility, ongoing support, and adaptation were so crucial for success,
Yeah.
what does that tell us about trying to get new practices adopted out in wild, outside of a research setting where things are even less predictable?
That's a really important question, isn't it? It suggests that the implementation work, the messy human effort of making change happen, is maybe even more critical and perhaps more challenging in everyday settings.
It really highlights that hidden effort behind any successful innovation.
It does. Maybe the real genius isn't just the idea, but the incredibly hard work of embedding it.
Makes you think, doesn't it?
Mm-hmm.
Perhaps paying more attention to the how, not just the what, could make all the difference in our own efforts to make change happen. Thank you for joining us on this deep dive.